Hi, everyone. Thank you so much for joining today's webinar. My name is Mary McCaskill, and I'm a research director at NatSun Social Research, and I manage the national evaluation of A Better Start. So I'll be chairing today's webinar. And just so you know, there are subtitles available. They should be appearing automatically at the bottom of your screen. But if they're not, then you can scroll to the bottom of your screen and you'll find the closed captioning function. We have a full agenda for our hour together, so I'll give you a brief introduction to the ABS National Evaluation and then hand over to my colleagues who will talk you through the evaluation objectives that are listed here, the methods, findings to date, and next steps. Throughout the presentations, please use the Q&A function to submit questions to us. There are a lot of you joining us today, and so we will monitor questions that come through on the Q&A, and we'll respond to as many as we can after all the presentations are complete. So to introduce A Better Start is a large program set up by the National Lottery Community Fund to support families to give their babies and young children the best possible start in life. It is being delivered through 5 partnerships in Blackpool, Bradford, Lambeth, Nottingham, and Southend-on-Sea. The national evaluation is being delivered by NatSun, University of Sussex, RSM, and Research and Practice, and the National Children's Bureau. So colleagues from NatSun, University of Sussex, and RSM lead on the evaluation research, and Research and Practice and National Children's Bureau convene a practitioner and parent panel, respectively. And the national evaluation has 4 key aims. These are to draw upon the evaluation objectives and provide evidence to the primary audiences that are listed here, to provide evidence that can support ABS grant holders to improve delivery over the lifetime of the project, to enable the fund to present evidence used to inform policy and practice, and to work with local ABS evaluation teams to avoid duplication and enable collation of evidence generated through the local evaluations. So the information that we're presenting today is from the first of 4 annual reports, and sharing findings in this way as they emerge annually is a key way that we're upholding our commitment to these aims. And as previously mentioned, there are 4 evaluation objectives, and they're shown here. And together, they're allowing us to develop a robust and comprehensive understanding of the impact of ABS. I'm not going to go into further detail about the objectives now, as you'll be hearing from each of the objective leads very soon. And underpinning the national evaluation are principles of contribution analysis. This slide here shows the steps involved in contribution analysis, which we are carrying out for this evaluation. Now, ABS is a complex program, and contribution analysis allows us to really lean into that complexity through creating a mosaic of different forms of evidence to evaluate the difference that ABS has made to the lives of children and families in the partnership areas. And here's the ABS theory of change. I appreciate there's a lot of detail on this slide, and we're not going to spend too much time on it, but you can refer to it back in the annual report. But this shows how the mosaic of evidence, represented by the squares, triangles, and circles, align with the different elements of the theory of change. Now I'm going to hand over to the objective leads, whose presentations really highlight how the different evaluation questions and methods are working together. And we're really excited by the findings that are emerging. So Andy, I will pass it over to you now.
Thank you very much. So I'm Andy Fugard, co-director of the Centre of Evaluation at NatSun. I'm responsible for Objective 1, which aims to identify the contribution made by the A Better Start programme to the life chances of children who have received ABS interventions. And more specifically, what we're aiming to do is to estimate the average causal impact of engaging with ABS projects on key outcomes for children under 4 and their families. And what this means is we're aiming to estimate the difference between the actual outcomes experienced by children as compared to what we estimate their outcomes would have been in the absence of ABS. And the way we're doing this is using a quasi-experimental approach, which will then be combined with the contribution analysis that Mary introduced earlier. We do this combining a number of different methodologies. One approach we take is ward level matching. So the idea is that ABS has been designed to focus on children and families who live in particular wards across the country. So what we have done, and I'll show you findings from that initial step in a moment, is match ABS wards with other wards in local authorities across England. We will obtain data from families in both the ABS wards and non-ABS wards from NHS Digital and from the Department for Education. Then we will use an approach called a weighting analysis. So the idea with this is to try to find and develop a comparison group of families that are similar as possible at the beginning of ABS, but in non-ABS areas as those who have engaged in ABS interventions. And by using evidence from both the wards and from the individual level data, we will be able to infer the likely causal effects of ABS. So as part of this process of the quasi-experimental analysis, we explored with the ABS partnerships what they thought the most important outcomes were for them. This is building on work that the sites have been doing since the beginning of ABS. And we also asked the sites for each of the projects, and there are around 120 projects across all of the different partnerships, which outcomes they saw as most relevant that those projects were aiming to change. And this slide shows the top 5 highest priority outcomes that partnerships were aiming to change. You can see that the most frequent outcome across the different projects was communication skills, followed by school readiness, perinatal mental health, and breastfeeding, both at initiation and 6 to 8 weeks after birth. So these are examples of some of the outcomes that we will be looking at. A sample of some of the other outcomes includes things such as Key Stage 1 and Key Stage 2 attainment, and also, for example, A&E attendances. So we'll be obtaining the individual level data next year, but we have some initial findings on the area level matching, which is shown in this slide. So we used a wide range of area level covariates to carry out the matching. Covariates just here means characteristics of those areas. And for some of the characteristics we looked at, it was reasonably straightforward to find good matches. So for instance, if we look at A&E attendances, you can see here that many good matches were found. Just to explain what this slide shows, each of the grey dots are non-ABS wards and non-ABS wards that weren't matched anywhere. The purple blobs are matched wards in non-ABS areas. And then we have, I'm not sure if you can quite see that, but orange blobs and yellow blobs. So the orange blobs are ABS wards in ABS local authorities, and the yellow blobs are non-ABS wards in ABS local authorities. And maybe just to explain briefly what's going on there. As ABS developed and as the different projects bedded in, then for many partnerships, the reach left the ABS wards into other wards within the ABS local authorities. So we've adapted the evaluation to take account of that to make sure that we can pick up all evidence of change across the whole ABS local authority. And briefly, the way to interpret this, to try to make sense of whether the matches are indeed good matches, is essentially the more horizontal these lines are, then the better the match is, because that's saying that for each ABS wards, we've been able to find a good match in the non-ABS wards. Now, if we move on to a characteristic of areas that was less easy to find good matches on, this is looking at the index of multiple deprivation. So if we look, for instance, at Lambeth, then it seems to have worked reasonably well. The lines are near horizontal for most of the ABS wards. But if we look at Blackpool, we can see that For the most deprived wards in Blackpool, there just wasn't a ward with the data that we had available to us to match with this. And this is an example of why the analysis that we're taking will be combined with other sources of evidence from ABS. So in this case, for any outcomes that we think might be influenced by deprivation, we'll have to treat the findings with a little bit more caution for Blackpool compared to, say, Lambeth. The approach we took to including beneficiaries in this evaluation is opt-in consent. So partnerships worked with us to develop this approach. We also worked with the parent panel to make sure that the wording of the information materials was as clear as possible. And we had a few loops of that to make sure that it was as clear as possible. And the idea is then that as beneficiaries enter the sites, they're given information and asked whether they want to opt in to having their information looked up. Now, by the time we get the information from NHS Digital and DFE, we won't know who anyone is. We just use that information so that NHS Digital and the Department for Education can give us a linked data set with all of that information. Given the complexity of this program, so I mentioned earlier, it's 120 projects, and that's conceivably 120 different routes into ABS. We have put in place mitigations in case there are insufficient consents. And in 2 of the 4 sites that are using this approach, rates of consents are currently low. We've considered a number of alternatives, and one is to focus on whole ward level outcomes. So we'll be exploring that and adapting our approach further as we confirm the number of people who've consented. So the next steps are to slightly bureaucratic steps, but necessary steps to prepare applications to request the relevant information, to finalize the data sharing agreements and the secure method of transfer of information between ABS partnerships and NatSen, and also to confirm the structure of the information that we will receive from the sites. So another important source of information here is information on what projects and services beneficiaries have engaged with. This will help us to draw inferences about what elements of ABS have been particularly successful. And if you have any questions, there's my email address. We can also ask questions on the chat. So I'll now pass across to objective 2.
Hi everyone, thanks Andy. I'm Eliza Garwood and I work in the Centre for Children and Families at NatSen, and I am leading objective 2. So objective 2 is about understanding how ABS is achieving its aims and making a difference in the lives of children and families. And the focus is on kind of what works and what doesn't work in achieving the 4 ABS key outcome areas: diet, nutrition, communication and language, social and emotional development, and systems change. Everything that I'm going to talk about today is based on qualitative interviews that we undertook last year. So we undertook 56 interviews with professionals across the 5 different partnerships, and also 13 interviews with non-ABS participants and 4 interviews with representatives from the fund. So I'm going to start by talking a bit about the similarities that we found across the key child level outcomes. Engaging families was one of those, so that was kind of highlighted as a key success, and building relationships and trust really helped engage families in services. Linked to that, connecting parents and carers through peer-to-peer support went particularly well, and that again helped encourage take-up and spread information by word of mouth. And thirdly, adapting services to improve accessibility was said as to be gone quite well, and that included things like having both day and evening classes, offering a drop-in approach, and practitioners reaching out to families directly. Things that were more challenging across all 3 child level outcomes were kind of the wider issues of poverty and deprivation, and we heard from a lot of participants about low quality housing, and also slightly more recently about the impact of the cost of living crisis, and the ways that that was impacting on families, particularly with nutrition, as they struggled to find low cost healthy food. Another challenge was supporting families to actually make changes. So one part of that was shifting generational mindsets, particularly for parents who themselves had experienced challenging models of parenting as children. And some practical challenges such as parents having a lack of time because of working or finding kind of correct spaces that they needed to use for services. Okay, so looking at diet and nutrition, that didn't move along, sorry. Looking at diet and nutrition specifically, we asked respondents what they thought the kind of key aims of the outcome area were, and they told us about improving diet and lifestyle choices for parents and carers, improving breastfeeding rates, improving children's oral hygiene, and reducing childhood obesity, and more recently ensuring that families don't go hungry due to the cost of living. What worked well was kind of encompassed in the last slide, but there was kind of some specific challenges for diet and nutrition, and that included quite a complex eligibility criteria to actually access diet and nutrition, some diet and nutrition services, and respondents talked about how they felt like there were low levels of referrals from partner agencies because of that. And they also talked about working with some less engaged groups as a particular challenge, such as formula feeders. For language and communication, again, we asked about key aims, and respondents identified both preventing poor communication and language, as well as actually improving children's skills as key aims. And in line with this, respondents talked about the importance of identifying children's communication and language needs early in life and intervening with support and specialist services as necessary. What worked well here was ABS services working really closely with early year settings and practitioners and building successful relationships there, and services providing free and tailored training really helped staff stay engaged with that. Respondents also talked about the fact that there was actually an increased focus on communication and language since COVID-19, and that the pandemic shined quite a light on the importance of this for families, and families were wanting to get kind of more involved and more support. What was quite difficult for communication and language was that there was high demand for specialist support, such as speech and language therapists, which meant long waiting times. Some professionals found it quite hard to identify if there were any communication and language difficulties for children who lived in families where English was an additional language. And so some practitioners weren't able to identify whether there was actually a speech delay or whether it was a language barrier. And supporting families to accept if a child had additional needs because of, you know, what they might fear what that meant, but also worry that they'd done something wrong there. And respondents observed that parents then might not follow recommendations, or they might not consent to the referral process. The final child level outcome is social and emotional development. So participants saw this as supporting parents and carers to build strong relationships, build resilience, and use that as a means to kind of manage stress and anxiety that might otherwise have been detrimental to child's development. What worked particularly well for this outcome area was sharing learning from ABS practice in non-ABS areas. So there were some respondents who worked in both ABS and non-ABS areas and used the learning that they gained from ABS in their non-ABS work as well. There were some more mixed views and experiences here, particularly around the referral process, with some having really great, successful referral rates, and others feeling like they were still getting kind of inappropriate referrals, such as for families outside ABS wards. And there was also some sort of mixed views about stigma, so the stigma attached to accessing support for social and emotional development. So some families might feel judged for it, but there was reported that there was some kind of change in narrative there, and that was kind of getting more positive. And what was particularly challenging here was evaluating social and emotional outcomes. Respondents commented that the scope of social and emotional development was actually really broad, and that made it quite difficult for them to find an appropriate tool to measure clear change. Right, the final outcome area is systems change, which kind of spans all of the key child level outcomes. So all respondents really talked to this outcome area. And the key aims here were focusing on prevention rather than acute services, collaborative working to make sure services were more cohesive and more joined up, and sustainability to make sure that ABS had a lasting impact and that any new approaches were maintained after funding ended. Collaborative working was identified as something that was going pretty well. Respondents talked about information and knowledge sharing, both between different professionals, but also between families and professionals. And there were some examples of ABS services working in partnership with each other and kind of complementing each other. Upskilling the workforce was another thing that worked really well here, and that included training on trauma-informed approaches, father-inclusive practice, and data collection and evaluation. And we saw kind of examples of that across the 5 different partnerships. Saying that data collection and management, there was kind of mixed views about it, mixed experiences, with some really successful examples, particularly where there was a more joined up approach, but it was generally seen as quite a challenge because it was quite time resource and intensive, and sharing data with the NHS was particularly difficult because different trusts had different data sharing policies and data management systems, and that made everything quite complicated. Other things that were quite challenging were that respondents felt that sometimes other areas were prioritised over early years, kind of in the wider area, such as kind of a focus on adult social care or A&E, and also that staffing and resourcing was pressured, particularly for those working in health and early years sectors. Great, and then I'm just going to quickly go over mechanisms. So we understand mechanisms are kind of how services and activities are done, or the kind of guiding principles that determine how a programme is implemented. And again, these kind of span all the child level outcome areas. So the mechanisms that I've highlighted here are some that we've talked about in ABS, not all of them, but the first one is test and learn. So test and learn aims to capture evidence and learning and improve future services through kind of a feedback loop. And for respondents, we heard examples of things like trying approaches on a smaller scale before deciding whether to expand them, refining and improving services based on kind of evidence and learning, and that included ending some services early if they weren't successful, and some ongoing monitoring and evaluation of projects, and that was through both kind of formal feedback and informal feedback from families and professionals. We also heard about sharing learning, which I've talked about briefly already, with ABS and non-ABS professionals, so sharing learning with local authorities, with NHS services, but also more widely with national policymakers. There was a lot of discussion about inclusion and making sure that services were engaging different families and different communities, and so people particularly talked about engaging fathers, engaging families from ethnic minority backgrounds, refugee and asylum seeker families, and families where English is not a first language. And finally, we talked to participants about co-production and how they thought that was going, and that includes kind of including families within service design and governance. So respondents talked to us about parents and carers being involved in the setup of services, but also kind of the ongoing delivery of services, but also sitting on partnership boards and being involved in decision making. And peer-to-peer support was something that was really highlighted as a key success of co-production across all the 5 sites, and respondents spoke about how parents within these programs acted as kind of agents of change in their communities, educating people about projects and encouraging kind of friends and families to get involved. Right, next steps for us for Objective 2. So this year we're having 2 waves of data collection with ABS partnerships. We're also having 1 wave of data collection with non-ABS sites and with representatives from the fund. Our thematic area for this year is parental engagement, which is very exciting. We are doing our annual programme activity mapping, and then there will be the first local evidence synthesis this year as well. Right, I'll finish up there. There's my email address if you have any questions, or yeah, I look forward to questions at the end. And I think I am passing over to Objective 3.
Thanks, Eliza. And I'm delighted to be speaking to you all today. I'm Janet Boddy from the University of Sussex, where I'm a Professor of Child, Youth and Family Studies. And our aim in Objective 3 is to evidence the experience of families from diverse backgrounds. Our focus has been on understanding what a better start means within the big picture of family lives over time. And our work today, as I'll go on to talk about, really highlights the importance of that big picture context for understanding what ABS provision can offer families. And that ties, I think, to what Andy and Eliza have already said. So we aim to learn from families with diverse backgrounds, and our sampling strategy reflects that. We're working in depth following a relatively small number of families over time, and so we have a very carefully constructed sample. We're not trying to be statistically representative of ABS families across the country, but the sample's emblematic of the diversity of families who work with ABS. So we're working with 25 families, 5 in each of the 5 partnership areas. And as you can see here, they've been selected to include a variety of different characteristics and experiences with ABS, including different levels of involvement with local provision. And in terms of the age groups, we've picked these 2 ends of the ABS age range for 2 reasons. The younger group lets us see the variety of families' involvement with ABS through that journey, through the 4 years of the study. And then the older group, Andy mentioned school readiness, the older group allows us to follow families' experiences as their children grow out of the age range for ABS provision. So this is a long-term research. We're going to speak to each family twice a year over a 4-year period. We'll visit once a year and do a telephone catch-up 6 months later. And we're using qualitative methods that are family-centred and family-friendly. So we interview the primary caregiver, but anyone in the household can take part, including children. And we have participatory activities that make it easy for young children and other family members to get involved. We give families cameras, and we also ask them to make a map together so we can learn about what's important to them in their lives from their point of view. And here you see a couple of examples of that. And it's clear from our work so far that ABS partnerships are reaching families with complex and intersecting needs. And this is true, as you can see here, for many of the families in our sample. The challenges that they're dealing with, I'm not going to talk through these in detail. The point I want to make is that these challenges are a really important context for understanding their experiences with a better start. Overwhelmingly, parents and carers emphasise the value of provision that supports them to be the kind of families they want to be, provision that facilitates their aspirations for their parenting and for their children. And the flexibility and availability of activities was seen as especially important in the context of busy and often challenging family lives. Affordability was particularly significant for families with limited financial resources, and inclusive activities were valued by families of children with special educational needs. Several families spoke about ABS facilitating access to opportunities that their families would otherwise struggle to provide, including opportunities that they recognise as important for their children's development. So, as we've heard, these are the areas of development that A Better Start prioritises: diet and nutrition, communication and language development, and social and emotional development. And across all 5 partnership areas and across all 3 developmental outcome domains, the importance of fit with family priorities was highlighted. Avoiding a deficit approach, recognising family strengths and recognising their concerns. And our analysis also shows how that fit between support and family priorities and with children's interests and preferences helped with embedding positive activities like healthy eating or reading with children into their everyday family practices. Relating to that, parents and carers valued interactive provision with space for tailored discussion in relation to those needs and priorities. And in some instances, that was preferred to more standardized or instructional approaches. Activities were also said to help parents and carers and children with building friendships and informal networks. And that emphasis they placed on social networks needs to be understood in relation to what I talked about before. A high proportion of families had limited informal support, and many of the parents we spoke to had experienced poor mental health. Informal spaces were also particularly valued by families of children born during the pandemic who hadn't had the same opportunities for socialisation when their children were younger. ABS also aims at systems change, and that was particularly evident in families' accounts of access to targeted and specialist support. We heard examples of this directly from ABS and through onward referral facilitated by ABS, that collaborative working that Eliza was talking about. And this was clearly crucial for families in identifying needs and managing complex challenges. Examples in our interviews included breastfeeding support, specialist speech and language therapy, domestic violence provision, and one-to-one support from people like ABS family mentors. Parents and carers have opportunities to get involved in different ways. And those who had done so described a variety of benefits, especially for themselves and their families. Some of them had been involved in shaping local services, and several people, as with this quote here, spoke about the difference that ABS had made in their communities, enriching opportunities for children and families, but also countering the stigma attached to the neighbourhoods where they lived. So considered as a whole, our analysis indicates that families' experiences of ABS had been positive, but there were also some common barriers and challenges across all 5 partnerships. One issue to come up was local awareness. Barriers to awareness and engagement were the most apparent for the families who were dealing with the most complex challenges. They knew less about what was available locally, and they found it harder to get involved. But the barriers to engagement were also often complicated, linked to multiple interconnecting factors. And for those families, continuity of support, including outreach and tailored engagement work, were clearly important for both understanding the barriers that they perceive and in order then to know how best to support their engagement with ABS. Beyond that, inclusivity was emphasised by several families, and that came up particularly in 2 ways. First, it could be a challenge for some families of children with special educational needs or disabilities. Some of those families had very positive experiences, but others said it could be challenging to bring their child to mainstream provision. And families with older children who were outside the ABS age range could also find it difficult to access provision sometimes. When older children could participate, that was really highly valued. So finally, next steps. We've completed those interim catch-up interviews with almost all the families, and we're currently analysing that material. And we're going to begin the next phase of in-person interviews in the next month or so. We're using similar methods, but also focusing in particular on areas of change and continuity in their experience. And we're also aiming to learn more from the second parent or carer where we can. So I hope that's given you a sense of what we've learned so far, but also that you can see how that long-term approach is going to be valuable in understanding families' journeys through ABS over time. Thank you. So I'll now hand over to Beth to talk about Objective 4.
Thank you, Janet. And hello, everybody. My name is Beth. I'm an Associate Director at RSM, and I'm here today to tell you what we've been working on in relation to Objective 4. Sorry, Janet, I seem to be going backwards instead of forward. Apologies. So just to recap, Objective 4 is to evidence the contribution that the ABS programme has made to reducing the cost to the public purse related to primary school age children. And in order to do that, we need to understand the delivery costs, the outputs delivered, any change in outcomes, any resulting change in public sector activities, and finally, how that changes the public sector spend. Mary, I seem to be having problems controlling the slides. Are you able to flick forward for me? Can you change? Thank you very much. The approach that we're using is called cost consequence analysis. It's been recommended for complex interventions like ABS because it captures a greater range of outcomes and it doesn't attempt to aggregate findings into a single unit. The outputs from our work will be presented as a disaggregated set of tables of costs and benefits, and some of those will be quantified and monetized, but also incorporating qualitative elements where appropriate. And our approach includes 5 sequential work packages as shown on the screen here. Next slide, please. Thank you. So the focus of our work in 2022 has been on the first work package, which is to identify and describe the programme delivery costs. So those include the ABS grant spend by partnership, the central programme costs, which is the time and expenses for the staff at the fund who are responsible for management and oversight of the programme. Then there is the support and the delivery activity costs, and that includes things like the development grants for developing the ABS proposals, as well as communication campaigns and contracts for the evaluation and learning contract. And then finally, there is leverage funding. So leverage funding includes any non-ABS grants, funding or donations that have been allocated to support ABS activity in each of the 5 partnership areas, as well as any non-monetary commitments from partners, such as the provision of services or facilities for a free or for a reduced fee basis. Next slide, please, Mary. Thank you. So this chart shows the grant spend by financial year, and that shows that the programme spend grew slowly during the test and learn cycle up to March 2018. And beyond that, you can see is where most of the programme most of the programme spend has been spent. Mary, please, thank you. We discussed various approaches to mapping ABS spend to outcome measures with each of the 5 partnerships. And based on their feedback, we agreed that each partnership would map their project spend to the outcomes based on the outcomes that that programme tried to change. Any remaining unmapped spend was then split by outcome on a pro-rata basis. And that unmapped spend might include things like the partnership's management costs, central programme expenditure, and any programme spend that they couldn't allocate to one outcome, either because it was historical or it covered all outcomes. And finally, any leverage funding that wasn't allocated to a specific project was then prorated. Thank you, Mary. So we split the central programme expenditure, which includes the central programme costs of the fund staff, time and expenses, as well as any support and delivery activity, evenly across each of the 5 partnerships. So that resulted in an extra £3 million being allocated to each partnership's overall spend. Okay. And during 2022, we worked with each of the 5 partnerships to map their project spend to the selected outcomes as far as possible. The outcomes were selected to align with the outcomes being measured in objectives 1 and 2. of the evaluation. However, in addition to the selected outcomes listed in the following slides, the partnerships also map their spend to a category of other outcomes. Now, those outcomes included some of the ABS common framework measures that aren't being measured through objectives 1 and 2, things like alcohol use in pregnancy or low birth weight, as well as partnership-specific child and parental outcomes such as social capital or community resilience. Excuse me. Analysis of the total spend per core domain across all of 5 of the partnerships shows that systems change presented. Sorry, Mary, could you scroll back? Apologies. Analysis of total spend across the core domains for all 5 partnerships shows that systems change represented the largest allocation. However, it's important to note that ABS is a complex and place-based programme. It's designed to be responsive to the needs of the local areas, and the test and learn cycle and no one-size-fits-all approach adopted by the fund has resulted in partnerships adopting very different approaches in response to local needs. And as shown on the following slides, this has resulted in big differences in the profile of their spend. Thanks, Mary. So we're just doing this in alphabetical order. This is the total spend per outcome for Blackpool. And this shows that the largest portion of Blackpool's project spend was allocated to achieving systems change. At least some of the spend from 26 different projects was mapped to this outcome. Thank you. In Bradford, the largest proportion of project spend was allocated to perinatal mental health, depression and anxiety. And the second largest portion of Bradford's spend was allocated to communication. Thank you. Lambeth allocated most of their project spend to the other outcomes categories. The second largest portion of Lambeth's project spend was allocated to child development at age 2 to 2.5, with 5 projects contributing spend towards that outcome. The other outcomes reported by Lambeth included things like social capital, breastfeeding initiation, preterm birth, and hospital admissions due to unintentional and deliberate injuries. The remaining roughly 8.5 million of the total project spend that was allocated to other outcomes was allocated to 6 different parental or child outcomes, including things like improved parental mental health and well-being, secure attachment to a trusted caregiver, improved maternal and physical health and nutrition, more families having stronger support networks, children having a BMI that is neither high nor low, and more survivors of domestic abuse are accessing appropriate specialist support. So those were outcomes that were unique to Lambeth and aren't being picked up through the national evaluation, which is why they're coming under other. Okay. And then for Nottingham, again, the largest portion of Nottingham spend was allocated to systems change, with 13 projects allocated to that outcome. The second largest portion of Nottingham's project spend was allocated to school readiness. And all of these tables are included in the annual report if anyone wants to peruse them in more detail. And finally then for Southend. So the largest portion of Southend spend was allocated to communication, with 14 projects mapping some of their spend to that outcome. A substantial portion of Southend's project spend was also allocated to perinatal maternal mental health, with 13 projects contributing spend to that outcome. Other outcomes in Southend accounting for more than 10% of their project spend were breastfeeding at 6 to 8 weeks and systems change, with 9 projects contributing to breastfeeding sorry, I've lost train there. And 18 mapping some of their spend to systems change. So what I hope you can see from these slides is the considerable variation in terms of the profile of how the 5 partnerships are directing their money and the outcomes that they're directing their spend towards, which for me, coming to this was one of the most interesting findings coming out of this analysis. And as I say, that shows a result of the tailored approach that ABS has taken in each of the 5 areas. So then finally, I'll just finish off by talking about next steps for objective 4. So we'll build on the analysis of the costs that we've presented earlier by updating those figures annually for the remainder of the evaluation period. The fund is currently undertaking a exercise to collate and validate output data for each of the partnerships, and it's agreed that the ABS National Evaluation Team will use the validated data set to inform our analysis of the effectiveness of ABS in terms of its contribution to achieving short-term effects. In terms of calculating benefits, that will be based on the evidence collected through objectives 1 and 2. For work package 4.4, we have undertaken a review of existing economic studies on the impact of early years interventions on public sector spending. And we'll supplement gaps in the existing evidence base with a series of interviews with practitioners later in the year. And then finally, we'll use all of the analysis from work packages 4.1 to 4.4 to produce a series of cost consequence summary tables, which will hopefully be of use to the fund and the partnerships, as well as other local commissioners and stakeholders as the partnerships progress their sustainability plans. So final slide for me then, just to say thank you all for your time. And if you have any questions, there's my email address. Thank you.
Great. Thank you so much, everyone. I found those presentations really interesting, and I hope that you have as well. I'm having a look at the chat because we have about 10 minutes now that we can have a Q&A if there's any questions that you have for the research team that you'd like to have answered now. And we're also interested to hear your reflections on the findings to date and on the national evaluation. So the most common question that's come through the chat is whether the slides will be shared afterwards. And so I'll just answer that one now. And yes, we are happy to share we are happy to circulate the slides. Also know that the webinar being recorded will be available to view back later. And all of the information can be found in the annual report. And we've also written a blog that summarizes some of the key findings. And so we'll take each objective in turn. So if you have any questions directly for the speakers, please do post them in the chat now. But I'll pass over to Andy. Andy, there's a question about referring to 2 out of the 4 sites rather than 5. Could you respond to that, please?
Yeah, absolutely. Sorry, I didn't explain why the 5 magically turned into 4. Yeah, so the reason for that is one of the partnerships has set up a very sophisticated pseudonymization platform within itself, which means that we don't actually need to then request data from NHS Digital and DFE. So for that particular site, they're able to share anonymized data with us directly. So we're using a separate process with them, and then the 4 sites are the 4 remaining that we're using the process as I described.
Great, thanks, Andy. And sorry, can you just remind us the context of the process, since it's been a while since objective 1?
Some days. Yeah, so the process for that is the beneficiaries who are accessing the projects at those various partnerships will be asked to provide opt-in consent and are providing opt-in consent. Then the idea is that we will collect that information on who has consented, share that with NHS Digital and the Department for Education, and then request pseudonymized data from them. So by the time we get the data, then all of that identifiable information will be stripped out, and we'll use that data to estimate the average causal effect of ABS.
Great, thank you, Andy. And we have a question now, Janet. I think this is one for you. There's a question about how or whether we're able to monitor experiences and outcomes of families where children have now aged out of ABS.
Yeah, no, I'm happy to answer that. And I think it's picked up across objective 1 as well, with some of the data that Andy and colleagues are analysing. So Andy might want to come in on that. But with objective 3, because we're following families for 4 years. So the oldest children in our sample at baseline are aged between 2 and 3 at the start of the study. So we'll follow them until they're 6 going on 7. And what we'll do is, if any families, I mean, so far we've had really good maintenance of the sample, but if any families do move away or decide they don't want to continue with the research, we'll, so long as they're within the ABS age range, we'll replace like for like in terms of that age range. And that allows us to follow experiences and outcomes for those families, but also to see how, I mean, if I give a very specific example, to see how practices like, and we've talked a bit collectively about the importance of work around language and communication across the site. So one of the things we see in the family data is changes in practices like reading to children, sharing books with children, doing story activities with children. How much are those kinds of practices maintained, and how do families understand that's shaped children's experiences of starting school? So following families in depth over time allows us to pick that up. And if I can be cheeky and pick up, there's another question about causality. And I think it's a question directed at Andy, but what I would say is there's quite a lot of literature within qualitative longitudinal studies about the capacity of that in-depth long-term research over time to understand complex causality in exactly the way that you see with the kind of that complexity and diversity across partnership areas of ABS. So while it's not causality in the sense that an RCT is testing or a quasi-experimental design is testing, it does allow you to see causal sequences over time in complex ways.
Thanks, Janet. Andy, did you have anything to add?
I'd love to pick up that question on causation. Thankfully, things have moved on. It used to be a knee-jerk reaction at the end of every paper that if you didn't run an RCT, you'd write the sentence that everyone knows and loves. Correlation doesn't imply causation. Times have changed. Actually, there's a long history of research showing causation from observational data. That smoking causes cancer would be a really famous one. Various studies more recently looking at the impact on COVID, that where people obviously for obviously clear ethical reasons weren't randomized to receiving COVID infections. So the key thing is the assumptions that we make and whether we can actually justify that those assumptions have been satisfied. One big assumption is that we have all of the most important alternative explanations of change in the area level covariates and in the individual information that we receive about individuals who've benefited from ABS. And I think the other important strand to this, really essential strand to this, is all the various sources of qualitative evidence. So it's when piecing all of these bits of evidence together that we are able to make some kind of causal claim, but that causal claim is conditional on the assumptions. So rather than a binary, did this or didn't it cause the outcomes that we see, we'll have a list of the assumptions that we're making and a narrative description of the extent to which we believe that those assumptions have been satisfied. I showed you an example of where it wasn't possible to get ideal area level matches for Blackpool because of the levels of deprivation experienced in one of the wards in Blackpool. So that would mean that any outcomes that we know can be explained by deprivation might provide an alternative explanation if change isn't as at high level in that Blackpool ward. And there'll be other similar examples depending on the particular outcome that we're looking at. But just, I would like to say really strongly, it's really important that we resist this idea that you have to run an RCT to establish a cause. If that were the case, then the whole legal profession would be out of business, for example.
Thanks, Andy. And I'm going to take two more questions, one for Eliza and then one for Beth. And thank you for sharing all your questions. I'm sorry we don't have more time to respond to all of them. But Eliza, there's a question about where you mentioned that messages spread by word of mouth in reference to peer-to-peer support, and the attendee would be keen to hear more about this, as well as parents acting as agents of change in their community.
Yeah, absolutely. Great question. Peer-to-peer support programs run in different ways across the 5 sites, and they were something that they were talked about a lot. Like I said, as a quite a key success. I think a lot of the messages that we were hearing were that actually this type of outreach was quite effective because it was quite an equal relationship. So that peer to that parent is quite an equal relationship to be able to discuss and think about what services would suit them. Sometimes it was the case that that mentor or that peer-to-peer support would go along with them to that service. So actually, like it was quite not just like, here's a booklet of what you've got. It was kind of a wider, more personalized, I guess, support than that. And that's why it felt like it was really successful. And as I said, kind of they were thought of as agents of change and connecting these families into these different services. I know we don't have a lot of time, but I don't know whether Janet wants to add anything to that.
I can, but I'm really sorry. I was answering a question in the
That's
chat.
all right. That's all right.
Do you want me to come in? Just give me a prompt.
Mary, what do you
So,
think? I know we've only got a couple of minutes left, whether we want
Yeah,
to
we
move on
only
to
have a
Beth.
couple of minutes, so in the interest of time, let's take a question from Eliza. And all of the questions that are coming through in the discussion is giving us very rich prompts for blogs and our autumn podcast and things that we can share in other outputs. So thank you. Beth, the question for you is, in terms of cost effectiveness of the program, is a hypothesis on what the longer term benefits may be in terms of cost saving, and is this built into the analysis, as it is often later in life that costs emerge?
Yes, so the hypothesis that we're operating under Objective 4 is that early intervention should lead to more appropriate and timely referrals and interventions, which then should lead to less intensive / expensive intervention during their primary school years. Now we have within Objective 4 bounded it to primary school years because there will be other interventions and other interactions that children have subsequent to ABS, and therefore, I don't think it's particularly reasonable to consider the full lifetime costs. And also, given the timings, not many of these children will have gone beyond primary school by the time we're reporting in the national evaluation. So that's why we're focusing specifically on those primary school years.
Great. Thank you, everybody. And just before we close, you can find more information and go into the content that we explored in the webinar today into much more detail by reading the annual report, which is available on our website. And then there's a thematic report that focuses in on place-based approaches. And later this year, we'll also be hosting a podcast, and you can look forward to another annual report. You can look forward to the second annual report and annual webinar that will take place in spring next year. Thank you again to all of our presenters and for joining and asking such strong questions. If there's anything else that you would like to chat through with us, don't hesitate to get in touch, and enjoy the rest of your day.